lesions are easy to maintain. There's no expensive hardware. When you put a stimulator in, the battery at least will need to be changed every 3 to 5 years. And also a consideration, if it's a big country and the patient lives far away from the center, lesions mean they can just go home and carry on with life. Implants mean they probably have to visit the neurologist much more often. And of course, if you compare the situation where you have to treat both sides of the brain, which most patients will require, lesions do carry higher risks. In looking at electrical stimulation therapy in the brain, I don't mean to go through all this. The idea actually came in 1960 from cardiac stimulation. All right. Once that started and that safety was shown, the idea was then taken that we could just put electrical therapy into the central nervous system. It was actually initially put into spinal cord stimulation and then directed towards the brain. So therefore, how do we choose patients? Essentially, we choose surgical candidates are patients who are advanced. We're not talking about early disease here. And essentially, patients become candidates once they have complications that are difficult to control medically. The point here, they must still be responsive to medication is important. So in general, the criteria would be PD for at least 5 years, all right? Not too late. They mustn't be in stage 5. Not too old. They mustn't be demented. They mustn't have excessive psychiatric issues to deal with. And they must show at least 30% improvement in their motor functions with medication. They must have realistic expectations, and they must be cooperative. These are what we normally tell our patients in terms of what they can expect, about 40 to 60% improvement in their fundamental Parkinsonian symptoms, right? This is a patient, you saw a short segment of his video earlier. He's here without medications. This gentleman was a carpenter. At the stage that he came to us, he was still able to work, but he was under threat of being fired. So he underwent the evaluation, and we found that he was quite suitable. He was about, I think, just in the early 50s at this point. This is him after surgery, again, without medications, all right? You can see that it's made a big difference. The circuit essentially has been modified by the effect of the stimulation. Okay, and you can actually see him in this segment of the video. You can see how he's able to turn quite effectively here. So after this surgery, he was able to carry on working. He worked, I think, for a further 3 years, and then now he's stopped working. Again, this segment of the video just to show you that he was very bradykinetic when he's off medication, right? This is him trying to do things fast. And then in the next segment, you can see him just after the surgery, all right? Pretty loosened up, again, without medication, all right? Not every symptom will respond to surgery. Postural instability is one of the more difficult ones, but as long as all these symptoms still respond to medication, they will respond to the stimulation. This is something that we're giving our patients now, something for them to understand and to modulate their expectations, because that's one of the biggest confounders in patient satisfaction, if they have unrealistic expectations. So we do make the point that whatever does not respond to medication is unlikely to respond to modulation with stimulation. In short, what we're trying to do, we're trying to address the off state when the medication loses function and improve it as much as possible. This is what the stimulator actually looks like. What does it do? Well, if you think about it, the stimulation drops into a nucleus, depolarizes it, but it also sends off signals, antidroming, orthodroming, into the overall network. This is an idea of what the electrical activity is actually doing. It's overriding pathological bursts, low-frequency oscillations, abnormal synchronization, disruptive firing patterns, and overall replaces them with more regular firing patterns. And functional MRI studies show that the effects of stimulation are actually fairly widespread. This is the work from the Cleveland Clinic group. There are two stimulators being placed here. Only the left one is being fired now, activated, and essentially you can see the stimulation is quite widespread in the ipsilateral basal ganglia and also to the contralateral superior cerebellum. Essentially the point being the stimulation affects the entire network, and that's how it works. PET scan changes can also be shown. Areas that were previously hyperfunctioning get modulated down. The team involves a fair amount of people, and the operation also is fairly complicated. It usually takes about a day to do the patient. There's a stage of surgical planning. We have to put this frame on the patient, and the patient has to be awake for a good part of the surgery. A lot of computer planning is involved. And when the operation starts, the patient is awake, all right? We have this thing, it's called a stereotactic frame, and it carries the needle. You might remember it from the earlier slide, but the whole idea is that the accuracy of this system is within millimeters. So meaning that if you want to go to one particular target, you need something that has this much accuracy. The operation is done through a single burr hole. That's the size of a 10-cent coin. Okay, we have a fairly complex set of equipment to monitor the activity of nuclei. Essentially, this is a path of an electrode as it goes from the cortex into the subthalamic nucleus. And essentially, as it passes through the thalamus and under the thalamus, you can record different levels of activity, and you can identify the subthalamic nucleus. So we have an electrical confirmation that we're on target. And then once we're on target, we're able to send electrical pulses, and then we can clinically confirm that we're on target. We must be able to make the patient better. That's why the patient has to be awake. Then we put the actual stimulator cable in, recheck everything, and at a later stage, once everything has gone satisfactorily, we then put the patient to sleep and implant the batteries in the chest. One more video. This gentleman, again, I'm showing you a fair number of foreigners, but we do have a fair number of local patients. All right, he's a Singaporean exile. All right, he lives in JB for economic reasons. Okay, he lives alone. His main quest was for independence. So this is him again in the off medication stage. He's not as bad as the first chap that I showed you. He can get out of his chair. Okay. But at this stage, he was, I think, contemplating getting a live-in carer. Okay. Here you're about to see our nurse clinician, Sister Lau. That's a leg over there. Yeah, she's about to come in now. Just about to test his balance, and you can see how easy he is to topple. All right. That's it. All right. The next segment shows you what he's like in his walking without medications. All right, so he's still able to get up and about. He's actually fairly early in stage 3, or midway, I would say. All right. Okay, so he's still able to get about. So then again, now you might ask the question, why would we offer surgery in this chap? But often it is a question of quality of life. He was looking to have better quality of life. Okay? And this is him after the surgery. Now again, he's off medicines now, and look at how he walks, all right? Essentially, you see him jump out of his chair. Now this, the surgery has actually made a big impact on his life. He's gone to being able to drive now, all right? That's restored his sense of independence, and he hasn't needed that carer. This is him again. He's getting out of the chair without any, he's off medications right now. And you can see there's balance has also improved just on stimulation alone. Right? It's not perfect, but it's a lot better than it used to be. And then the next segment of the video shows you when we've got him in sort of the tip-top condition. He's got about 1/5 of the medicines that he had before, and he's being on the stimulation, you can see. All right? Much brisk, better arm swing, right? Much more comfortable. And the other segment again showing you his balance, right? He's able to jump, get out. It's not as easy to topple now, you can see. Okay, but if Sister Laut really tries, she can. Okay. Okay, and this is another point. One of our patients here, he appeared in a little article about him in the Today paper. Point again, after the surgery, his quality of life improved enough that he was confident enough to go on holidays. All right. Prior to this, he wouldn't. All right. So he's essentially a very happy man now. He's a retiree, and I suppose he's traveling everywhere now. Our results, we've got about slightly more than 20 patients now, but I'm just presenting 20 here. 3 of them were women. Essentially, we've been on target in every one of them. Patient satisfaction, 18 out of 20. What do I mean by this? We've got more rigorous assessments of patient satisfaction, but that's a work in progress. We're preparing a paper. So here, essentially, we just got the nurse clinicians to ask the patient, are you at least 60% better? Yeah, 18 of them did. They said, we're at least 60 to 80% better. What did the two of them say? 2 of them are not entirely happy. One of them was really about patient expectation, really. We've been able to control his dyskinesia, and his mobility has improved, but he just wants to be so much better than that. But he's not entirely happy. But another patient was a difficult patient from the word go. He's got young Parkinson's. He's about 45 years old. He has responded, but then again, he's not easy to satisfy. In terms of complications, if you think about what can happen in the things that we're doing, I mean, we're putting a needle into the brain in someone with Parkinson's disease. Hemorrhages are the worst things. The lead can displace. They can get infected. Those are the big 3. And the stimulation can sometimes lead into all sorts of other problems, meaning they get unwanted side effects in terms of feeling funny sensations. Sometimes they get double vision. All that hasn't happened, all right? We haven't had any side effects. We haven't had any lead migrations. We had one asymptomatic hemorrhage. This is on a post-op CT scan. The patient didn't have any symptoms. We've had a couple of infections. These were delayed, not immediately after surgery. One happened about 3 months after. One happened 4 years after. So the results have been fairly decent. And essentially, if you look at evidence-based type data, they're coming. Randomized studies are in progress right now, but this meta-analysis will tell you where the state of things is right now. It's generally acknowledged that this therapy will reduce medication requirements by half, all right? Significantly address dyskinesia and off periods, and quality of life will be improved. Where are we going? Well, it's very much like someone has discovered a hammer and everything looks like a nail, all right? This therapy is being directed at just about everything right now. Standard indications, dystonia, essential tremor, writer's cramps, these are well documented uses, but potentially in epilepsy, in pain, psychosurgery. A lot of this is driven by PET studies, which can basically show that areas of the brain are hyperfunctioning or hypofunctioning. And this is a picture of what happens in depression. This is called area 25 in the inferior frontal gyrus, medial frontal gyrus here. It's hyperfunctioning, and in patients with very severe intractable depression, if you put a stimulator in here, you can at least get 30 to 40% of them significantly better, and that's the idea. Essentially, if you have a hyperfunctioning area, you can depolarize it. If you have a hypofunctioning area, you can stimulate it to function better. So if you look at where we're going, I think it's still early days. The therapy has a lot of promise, and we've shown some good results. But the point again, we're working with a team. And I hope this has made your afternoon worthwhile. Thank you.